Hi, everybody. My name's Mike Siah. I'm a vascular surgeon in Dallas, Texas at UT Southwestern. And I've got a really cool case here where I utilized Javelin to treat a patient who had multi-level disease. So not only did they have below the ankle disease, but they had femoral popliteal and tibial disease. And I was able to successfully complete this case by using Javelin. So tale as old as time right here, a patient with critical limb-threatening ischemia is 84 years old, a history of end-stage renal disease, heart failure with a preserved ejection fraction, hypertension, and lupus with a non-healing right foot ulceration. Interestingly enough, this patient on their left lower extremity had previously undergone a deep vein arterialization and subsequently healed a transmetatarsal amputation. So sure enough, when I saw this patient's non-invasives, which demonstrated non-compressible ABIs as well as a toe pressure of only 18 millimeters of mercury, I was initially thinking that this patient would need a deep vein arterialization. In addition to all this, the patient's got a really high BMI, and that had an influence on our surgical planning. Generally when people have large PANIS or they have elevated BMIs, I think I really struggle with antegrade arterial access and managing that access site. So routinely get up and over access, which can be seen here. So via up and over access from the contralateral left groin, you can see angiography demonstrating a widely patent common femoral as well as superficial femoral artery. In the SFA or the distal SFA approaching the P1 segment, we've got a high-grade stenosis of the distal SFA, but it's very, very focal. And then going down below the knee, you can see geniculate collaterals perfusing the distal tibial vasculature prior to the popliteal artery. But even when you look at the anterior tibial artery, there's a focal short segment occlusion and sort of diffuse disease along the length of that anterior tibial artery. The tibioperineal trunk appears patent, but both the perineal artery and the posterior tibial arteries appear occluded. So at this point in time, I'm pretty sure, I'm going to be treating the SFA. I'm going to be treating the proximal AT. I want to know what the outflow is, but sure enough, despite angiography from the distal SFA, you can see sort of the flow of contrast through that anterior tibial artery becomes increasingly challenging to see. And in my opinion, that's generally indicative of some below the ankle disease, but oftentimes knowing that I have some perfusion below the ankle is enough because I know I'm subsequently going to get a support catheter down beyond that AT disease into the distal anterior tibial artery. And at that point in time, I'd like to take a dedicated shot. So after having put my big sheath in, crossing the SFA, popliteal, and the anterior tibial lesions with a catheter in the distal anterior tibial artery, you can see severe disease of that dorsalis pedis, focal, heavily calcified, short segment disease, but oftentimes this can be incredibly challenging. So in general, when approaching these multi-level disease patients, I like to treat from distal to proximal. So the first lesion I wanted to treat was that dorsalis pedis lesion. And given the fact that we're very distal, we're coming up and over, and that we're traversing, the disease in the SFA as well as the anterior tibial artery, I recognized that I was probably going to be dealing with some resistance in delivering the device. But I was really, really surprised in that dorsalis pedis lesion precluded my ability to deliver a low-profile conventional angioplasty balloon. So I tried and tried and tried, but was unsuccessful. So then I sort of resigned myself to treating the inflow first, and then by relieving that sort of resistance in the system, maybe it make it a lot easier to subsequently treat that dorsalis pedis. So in the second image, you can see me using a long, regular conventional angioplasty balloon to treat that anterior tibial artery lesion. And I also treated that SFA lesion with some intravascular lithotripsy. But even after having done that, I still really struggled to get, in this time, a low-profile coronary balloon across that CTO. When I struggle to deliver technologies, in the BTK or BTA space, I usually try to use low-profile balloons first. But when that doesn't work, I think about using things like orbital atherectomy. So at this point in time, being unable to deliver a balloon, I tried to deliver a Viper wire so that I could subsequently, perform orbital atherectomy. But because the Viper wire was so non-steerable, I wasn't able to get it to traverse that CTO. So I sort of left there with a nitinol tipped wire capable of crossing that lesion. I'm not able to get the Viper wire across it, sort of at my wit's end. I'm not sure what to do. So at this point in time, I thought about using the Javelin device. And when I think about the Javelin device, we were fortunate enough to use it in in their trial. So sure enough, I delivered the Javelin all the way down to that distal sort of cap of the dorsalis pedis artery, and I delivered 5 cycles of pulses via the Javelin catheter here. And I really mashed on it. I pushed really, really hard while delivering those cycles. But unfortunately, I was really surprised to see that the Javelin device wasn't able to cross the lesion. And this never happened to me in any of my experience utilizing the Javelin, right? In every single patient that I've ever used the Javelin in the trial and post-commercial release, the Javelin has always crossed. So despite giving 5 cycles, this is the last case of the day, I wasn't sure that, I was frustrated because the device didn't work, right? And when I say that, I was frustrated because the device didn't cross. I took the Javelin device out and I went back with that same coronary balloon that I had previously used that had already been inflated, and I was able to cross the lesion in the dorsalis pedis and subsequently balloon it. And I was very, very surprised that despite not being able to cross the CTO, I was able to deliver my balloon. So clearly the Javelin did something to modify the plaque, to change the compliance of the blood vessel, that ultimately was able to get me the result that I hoped to achieve, which was inline flow via that anterior tibial artery all the way out to this patient's sort of forefoot. And you can see on the images 3 and 4, you can see a fantastic projection in the AP projection of perfusion going out to that forefoot. And then from the lateral projection, you can see, despite it being an incomplete pedal loop, you can see flow going to the dorsum and the plantar aspect of the foot. Right, and this patient had previously undergone a transmetatarsal amputation prior to me taking them. So that perfusion to the dorsal and plantar aspect of the foot is absolutely critical when you want to see patients heal transmetatarsal amputation. So this case is about 6 weeks ago. So that patient had undergone a TMA. We did the arteriogram. And now we're in that challenging point after these types of procedures where we can see that this patient is doing well, but they're going to need more time. And when we think about sort of the time it takes to get wounds to heal after complex lower extremity intervention, median rates of wound healing approach 200 days. Now we're 6 weeks out and we're close to getting this patient completely healed. And not only are we close to getting this patient completely healed, but we're leaving this patient with a transmetatarsal amputation. So he will subsequently, despite presenting with critical limb threatening ischemia, right, despite having toe pressures that weren't consistent with wound healing, this guy's on the pathway to having a fully functional lower extremity. And I think that's what all this therapy is about. And at the end of the day, I wouldn't have been able to do it. I wouldn't have been able to get flow out through the dorsalis pedis without the utilization of the Javelin catheter. When it comes to all the other tools that we have in our armamentarium, getting and being able to deliver these tools across the entirety of a lesion is a prerequisite to anticipating success with any technology. But sure enough, I was really surprised to see that this device, while it did not do what I historically considered to be the primary measure of success, it was able to modify the plaque in a way that safely allowed me to subsequently deliver the definitive therapy, right? So I was able to deliver lithotripsy to the proximal cap, and that was all I needed in order to deliver my balloon. And I think prior to this, if somebody had told me like that's okay with any technology, I would have looked at anyone who'd say that to me like they have, 10 heads. It's just so different than everything we've thought about prior to this. But I was really impressed, and I was very happy that I was able to get the result I wanted to achieve when I thought sort of all hope was lost. The biggest thing about this technology, or the biggest thing that I can share with other physicians, certainly the notion that time is your friend. Using it and not necessarily seeing the catheter move doesn't necessarily mean that the device isn't doing what it's intended to do. And being patient and tolerating that, because despite not seeing the catheter cross lesions, you can still ultimately prep the lesion in a way that facilitates definitive therapy. And that's the most important. So I think for me, my thoughts on Javelin have actually changed. They've changed as a result of this. This is something that I would use, in lieu of sort of orbital atherectomy, when I couldn't get something across, especially if I didn't have the ability to sort of exchange for an appropriate wire to do orbital atherectomy with, because you can use Javelin over your standard wires that you use to cross, which, I think makes things a little bit more convenient. But, seeing how this isn't a crossing catheter, but doesn't purely work like a crossing catheter, the way I've thought about this is it's kind of allows you to deliver lithotripsy in locations along the entire length of a wire, especially if you're treating multi-level disease. You can use it to treat an SFA, a popliteal, and a tibial artery, especially in the setting of a CTO, and derive the benefits of lithotripsy without having to open 3 or 4 different balloons, right? You're selectively choosing where you're tailoring your lithotripsy therapy, and then subsequently following it with whatever therapy you choose to want to use. And I think that provides the physician with a lot of autonomy, and it allows them with a lot of control over how they want to treat their patients. So I think it's twofold. It can work as a crossing catheter if you choose to evaluate it like that, but it's so much more than that. It sort of has become a new tool that I'm more cognizant that I have in my armamentarium, and I'm thinking about it, especially because there are those unique clinical scenarios where all you can do is get a wire across a lesion, whether it's a tibial or a pedal vessel, and you can't get a support catheter, you can't deliver a balloon, even if you sequentially balloon along the length of that lesion, you ultimately can't get it to cross the lesion. I think in those patients who may certainly not have been open surgical bypass candidates, and you're unsuccessful to deliver your therapy from an endovascular standpoint, those are the types of patients that I think about doing DVA in, right? And maybe that this tool has the ability to, do less DVAs potentially, especially this is a great example of that. The patient had a contralateral DVA, right? If we're able to be successful having used the Javelin to treat that dorsalis pedis and get inline flow all the way out to his TMA, we've saved this patient the sort of process that takes 3, 4, sometimes 5, 6 months to heal as a result of the DVA. We might be able to get this patient with a fully healed transmetatarsal amputation and save that as an alternative down the line should they need it.